العلم يحلو كلما كررته، ولذاك عدت مكررا لحلاوته، وبكثرة التكرار يكثر نفعه، وبكثرة التكرار يكثر نفعه، فادأب لتعلم من فوائد حكمته.
Okay, so this will make it interactive, and we need your participation. And usually in lectures they tell you to turn off your phone. This one will tell you to turn on your phone but don't talk. We will use it as a calculator because we will need to calculate things together. So now I've been to the unit here in Ahmad Maher Hospital. It's an excellent unit. They do venous blood gases. Anybody does arterial blood gases? How about capillary blood gases? Venous blood gases? Okay, so most people do what? Do capillary or venous? Capillary blood gas. Okay. So the blood gas, okay, arterial blood gas is an arterial blood gas. You get it from an artery, and we will talk about the differences between arterial, venous, and capillary. But generally, what we get in the report is two types of information. One is about acid-base balance, pH, PCO2, and calculated bicarb. And the second part is about oxygen, PaO2, and calculated SAT. So basically the blood gas is two different stories. One story about acid-base and one story about oxygen. Oxygen will be significant in arterial blood gas. We'll talk about a little bit about if venous blood gas, I guess, since you do venous. What is the significance of PVO2, the partial pressure of oxygen in the venous blood gas? But mostly, let us focus first on the acid-base part, then we'll talk about the oxygen. Okay, so pH is measure of the acidity or alkalinity. Neutral is 7, so our blood is alkaline. CO2 is dissolved carbon dioxide in the plasma, and PaO2 is the partial pressure of oxygen that is dissolved in the plasma. Okay, so it's clear that PaO2 is partial pressure, or the PaCO2 or PaO2. This is in the arterial because it's A. Small a is arterial, big A is alveolar, standard. So arterial CO2 is dissolved in the plasma, the CO2 that is dissolved, and the arterial oxygen, partial pressure of oxygen, the pressure of oxygen that is dissolved in the plasma. These three things are measured. The blood gas machine will measure them. Okay, so they're very accurate. Obviously, depending on the accuracy of your blood gas machine, but generally, bicarb, base deficit, oxygen saturation are calculated numbers. Okay, and we'll see how the calculation can be different from the truth, and the calculation, if they can calculate it, so can you. And that's why we need your phone. Okay, so the blood gas will tell us about acidity, about oxygen and carbon dioxide. Most importantly, the pattern of change. When I look at the blood gas, I never look at one, okay, unless it's an emergency. Okay, I always want to look at this one and the one before and see what happened in between. What is the difference? Because pattern of change is very, very important in your a intervention with a blood gas machine. Okay. Okay. So these are our basic definition. There is acidosis and there is acidemia, and there is alkalosis and there is alkalemia. Our body is good. Subhanallah, yani we're manufactured to adjust our condition and improve, acclimate and adjust to changes. So acidosis is something that adds more acid to our system that will lower our pH if we didn't have enough buffer. So we have a buffering system. When actually the acidosis turns our blood acidic, it's called acidemia. Our buffering mechanism had failed or exceeded its capacity to adjust and to maintain our normal pH. So acidosis is a process. It's something that adds more acid. It may not change our pH, okay? But when our pH changes, then to the acidic side, it becomes acidemia, less than 7.35 on the arterial side. If our pH changes more than 7.45 on the arterial, then it becomes alkalotic, or 7.45 in anything. Then that's alkalemia, okay? So there's a difference. There can be an acidosis going on, but our pH is normal. So just because our pH is normal does not mean that everything is fine. There can be a process of alkalosis or acidosis that is active. So why are we worried about alkalosis, acidosis? Because if you have really low pH, our cellular function will start affected. Our cardiac contractility will be affected. Also, pH above 7.8, most of our enzymes will not work well. So acidosis, alkalosis, or acidemia and alkalemia are not good for us. We'd like the pH close to 7.4. So the buffering system we have 3 buffer system, which their function is to maintain our pH within normal range so our enzymes and activities can work properly. Which are the most important of, which is the best buffer system, strongest buffer system we have? Bicarb. Okay, so the bicarbonate buffer system, hemoglobin, phosphate, plasma proteins to a much less extent. The most important buffering system we have is bicarb. And this is how it works. Okay, H2 plus CO2 gives you HTCO3. HTCO3 gives you bicarb ion. Should be minus here, but I couldn't put it. And H ion. This needs carbonic anhydrase. So this takes a little bit longer than the one on the left. The one on the left is quick. The one on the right is a little slower. Okay? So the first thing is we'll look at the pH. So we'll decide, is there acidosis, alkalosis, acidemia, alkalemia? And then we'll look at if there is compensation on one side or the other. And finally, we will decide what is the primary problem, what is the secondary compensation for it. Okay? So now, usually when there's compensation, like if there's acid coming into our system because of sepsis, because of something we swallowed, or because of inborn errors of metabolism, now there's more acid. Our body compensates for this acid, okay? But it does not overshoot. Like normal 7.4, if we have something that makes us acidic and our pH drops to 7.25, our body tries to compensate it to bring it close to 7.35, 7.34. It never, our body when it compensates, it does not go up to 7.42. Okay? So it will not overshoot. The compensation does not overshoot. This will help us decide which is primary, which is secondary. Second, with the pH will tell us which side the pH is on, will tell us what's the primary problem within range. We will see some exceptions now. After determining the primary and compensatory acid-base balance problems, then we'll look at oxygen. So normal value pH 735, 745, that's arterial. Venous will be a little more acidic, so because we have a buffering system, it will still be close to this. PCO2 35 to 45, that's arterial. Venous will be 5 more. And we'll look at the number now. Now the tricky part is bicarb, because bicarb is calculated. So the blood gas machine, it is set for adult value. It's not set for babies. So normal adult bicarb is 24 plus minus 2. Babies, newborns, particularly preemies, they have a lower renal threshold, so their bicarb is lower. If you actually measure it and the electrolytes, it will be low. But in the blood gas machine, it will read it as normal. Okay, so if it tells you that the bicarb of the baby is 22 or 24, it does not mean that the baby is having high bicarb. This is just what the machine reads. Okay, now this is where we'll need your calculator. A change of PCO2 of 10 will result acutely. This is an acute condition. A change of pH of PCO2 of 10 will result in a change of pH of 0.08. PCO2 10 will change pH by 0.08. If PCO2 goes up, what happens to the pH? Goes down. If the PCO2 goes down, what happens to the pH? Goes up. So they go opposite direction. Okay? A change of bicarb of 10 will result in a change of pH by 0.14. Okay, now if the bicarb goes up, what happens to the pH? It also goes up. Okay, if the bicarb goes down, pH will goes down. We'll try not to have too many numbers to remember, but these are the only two numbers you need to know, and you need to know what's the baseline. pH 7.4, PCO2 40, and bicarb of 24. That's the baseline arterial blood gas. Okay, so all right, we have a baby, 30 weeks gestation, arterial blood gas 713, PCO2 60, PO2 of 79. What's your diagnosis? So we said first we'll look at the pH. What is the pH? Tell me. Okay, we want one person to say, what is the pH? Nobody wants to volunteer? Acidosis, okay? This is acidosis and acidemia, okay? Because the pH dropped. So call it acidosis. Now, is it respiratory or metabolic? Respiratory. Is there, so we decided that there is pH is low, it's acidemia. Decided CO2 is high, because we said 40 is normal, so this is respiratory acidosis. Now, is this pure respiratory acidosis, or is this mixed respiratory and metabolic, or is this compensated? There is metabolic compensation. How do we decide? How do you decide? Someone said mixed. How do you decide it's mixed?
Increase CO2 10, decrease part OL.
Okay.
It means 60 means pH 7.24.
Okay. So he calculated that the CO2 is 60, which is 20 above the normal, which is 40. So the 20 CO2 up, each 10 will decrease pH by 0.08. So if you have up by 20, you'll decrease the pH by 0.16. So normal pH is 7.4. Subtract 0.16, then it should be 7.24. But this is not 7.24, this is even lower, which means there is also metabolic acidosis. Okay? You get that? Okay, again. Okay. We want to know if this is acidemia, acidemia. Correct? This is the easy part. Now, CO2 is high, so we have respiratory acidosis. Now the issue is it only respiratory acidosis, or is it combined, or is it compensated? There is some compensation, but not full. Compensation can be partial or close to full. It will never overshoot, as we've mentioned. We'll give you some examples, a little tricky on that, but we'll see. Okay, so now CO2 is high. We say if you bring the CO2 down to 40, you ventilate the baby and you bring the CO2 down to 40, what will happen? What would the pH be? So from 60, you'll bring it down to 40. Each 10 will change the pH by 0.08. So by bringing it down 20, you will increase the pH by 0.16. Because 0.08 for each 10. So add 0.16 to this number, it will be 7.29. Still low. Which means There's a metabolic component. There's only respiratory and metabolic. There's nothing else. Okay, metabolic can be hundreds of different things, but it's either respiratory or metabolic. Okay, so we decided that this is combined respiratory and metabolic acidosis just by looking at pH and PCO2. Okay, we can actually calculate the bicarb. Okay, how can you calculate the bicarb? Okay, we just said 7.29. So from 7 to make it normal, 7.4, you need the pH to go up 0.11. And we said each 10 bicarb will change the pH by 0.14. So this is less than 10 bicarb, like maybe 7, 8. So the bicarb dropped by 7 or 8 from normal 24, it comes to 17. So the bicarb for this blood gas will be 17. So we can calculate the bicarb just like the blood gas machine can. You got the last part? Yes? Okay. Okay, now you put the baby on the vent and you repeat the ABG. Now 7.29, PCO2 45, oh sorry, PO2 79. So now what's your diagnosis? Okay, so now we're still acidosis acidemia, right? Okay, now PCO2 is normal, right? So this is the 7.29 that we were just talking about. That we corrected the CO2, now the pH is completely corrected from a respiratory point of view and you still have acidosis. So this acidosis is metabolic. Okay? And as we've mentioned, we can say the bicarb is down 7. Because to make this normal, 7.29 to 7.4, 0.11. Okay, so I need 7 bicarb to give me 0.11 because 10 bicarb give me 0.14. You get that? Okay, we'll do a couple more so we'll get easier. Now same baby. 3 weeks later, he's on CPAP, blood gas 7.31, PCO2 58, PO2 79. What's your diagnosis? Okay, so his acidosis acidemia, pH is less than 7.35. Okay. Now, respiratory, is it respiratory? Yes, it's respiratory because the PCO2 is high. So we have respiratory. Is it pure, combined, or compensated? Yes, we want someone else to talk. Someone from the back, people. Yes. We need hands. Yes, go ahead. How do you know it's compensated? Good. 7.24. Okay, so with the CO2 alone, let's assume it's 60. And the numbers are close. So it should drop the pH from 7.4 to 7.24 because each 10 CO2 should drop the pH by 0.08. So 20 CO2, let's assume is 60, close enough. So 0.16, so the pH should be 7.24. But the pH is not 7.24. The pH is what? 7.31. So this means something brought it up. What can bring it up? Metabolic alkalosis. Okay, so there is metabolic compensation. Okay, how much is your bicarb now? Now we brought it from 7.24 to 7.31, which is 7. Correct? So 10 bicarb gives you 0.14. Now 0.07 will give you be how much bicarb? 5. So your bicarb in the blood gas machine would be what? 29. It would be 24 plus the 5. Okay, clear? Okay, we'll do some more. So now same baby. Okay, and this shows you the importance of trending. Now he's intubated because he's going to have hernia surgery. So you put him and ventilate him. Now this is the blood gas, 749, PCO2 50. What do we have? We have alkalemia, alkalosis, alkalemia. Okay, what is the CO2? Okay, so this means what? So he has metabolic alkalosis compensated for by respiratory acidosis. True? No? This was the kid 5 hours before. 7.3158 CO2. Okay? If this is the only blood gas we have, then this would be our diagnosis. That it is metabolic alkalosis compensated for by respiratory. But here, because I've seen the blood gas before, this kid had higher CO2 retention. So when you ventilated him and blow off his CO2, you brought the pH quickly up. Okay? Because he has some high bicarb. Why didn't the bicarb drop right away? Exactly. Metabolic takes time. So if you leave him, then eventually his pH will come down. Because the metabolic adjustment takes time. Respiratory adjustment happens very quickly. Yes? Okay. Here, this baby has chronic CO2 retention. So when you have chronic CO2 retention, your body, by the equation we've seen, will compensate, will make bicarb. Okay? So the body, because the body tries to correct the pH. So, yes, go ahead. مشكلة ازاي؟ هو ده initially can mixed. 3 weeks later, after 3 weeks, he's sick. He's poorly perfused, he has CO2 retention, he needs a fluid bolus, so you give him the fluid bolus, you ventilated him and you made him okay. So we finished this part. This was his first gas. Okay? This was his first gas. He was sick. Okay? You put him on a ventilator and you improved him. Right? Now his pH is better, his PCO2 is better. 3 weeks later, now he's in your unit for 3 weeks. You extubated him, you put him on CPAP, and he's okay. He has some CO2 retention on CPAP, but he's compensating reasonably okay. So his pH is acceptable, his PCO2 is acceptable, and he's okay. So he doesn't have a metabolic problem. Okay? So now you intubated him for something else, not because he got sick. So his CO2 is still high, still 29. Once you intubate him, you can bring down his CO2 quickly, because now you're ventilating him. So you brought down his CO2, now his pH goes up, because you blow off his CO2. Leave him alone for a couple of days, his pH will come down, because his bicarb will drop. But this is the important part about knowing what the previous blood gas was. If this blood gas alone, I would call it this. I would call it metabolic alkalosis compensated for by respiratory acidosis. Why am I calling it, why would you call it, what would you call it? Tell us. This is the only blood gas we have. We don't have anything else. What would you call this one? First look at the pH. What does the pH tell you? No, go ahead. She's going to tell us. pH, alkalosis, alkalemia, okay. CO2. CO2 is high. So it means respiratory acidosis. So respiratory is not the primary problem. Respiratory, because the pH will be on the side of the primary problem. Because we're not going to overcompensate. So respiratory acidosis is not the primary problem. The kid is alkalotic. So the primary problem is metabolic. This is the only thing they're left. So it's metabolic alkalosis compensated for by respiratory acidosis. So this is how I would interpret it if I only have this one blood gas. Okay? I'm just showing you that you should not go by one blood gas. You should look at the one previous.
But what we say in this position now is...
I would say this baby has chronic CO2 retention with metabolic alkalosis, and now I'm ventilating him. So if you want, so this is not metabolic alkalosis primary, because I know he's not metabolically alkalotic primary. So that's why I need to see trends, not just go by one blood gas. Okay. So what? And more importantly, if you have this blood gas in your hand, what would you do?
Wait and see.
Wait and see. Okay. Most important thing is you actually go to the baby and figure out what's going on, because we're not going to treat a blood gas. We will treat the baby. So go to the baby, decide what's going on with the baby, then make your decision. Don't make decisions based on blood gas alone. Okay. You want to practice some more? Okay, let's do this. We'll finish 10 minutes. We'll do 5 minutes of example, then we'll go to oxygen, because oxygen will take a little time. Okay, first baby. 4-month-old with RSV pneumonia. pH 7.2, PCO2 65, bicarb 35. We're making your life easy. What does he have? Okay, respiratory acidosis. Is there compensation? Well, probably CO2 is a little too high. Okay, because this is basically pure respiratory acidosis. Forget the bicarb part. Okay, because 65 CO2 will bring down your pH by 0.08, 0.08, 0.04. Correct? So together will be 0.2. So will be correct pH. Okay. 4 days old male with tachypnea, tachycardia, pulseless lower extremities. What does he have? Okay, in the blood gas. Okay, let's do acidemia, acidosis. Okay, metabolic or respiratory? Okay, we want someone from the back. Respiratory? Respiratory what? So what is the respiratory part? PCO2 30. It's what? It's alkalosis, or see, alkalosis is the process. So it's respiratory alkalosis, but the baby is acidotic. So it is metabolic acidosis, pure or compensated. Okay, so it's partial compensation with respiratory alkalosis. So this is acidosis, acidemia. It's metabolic because the PCO2 is low, and it's partial compensation by respiratory alkalosis. Clear? Yes? Okay. 4 weeks old infant with frequent vomiting because of pyloric stenosis. What does he have? pH 7.55. What does he have? Okay, so just pure metabolic alkalosis or something else? Okay, almost pure because PCO2 45 close enough, so he just had lots of hydrochloric acid vomiting, so he has metabolic alkalosis. Okay, 15-year-old female, with panic attack, hyperventilating. So alkalosis, alkalemia, respiratory or metabolic? Yes, no, maybe? Okay, so respiratory alkalosis, because usually this is an acute event that takes place. Okay, just to mention, arterial, capillary, and venous. So in arterial side, you have pH of 7.4. We said everything plus minus 0.05. Okay, but pick one number because it makes it easier for calculation. So the 7.04. Venous has higher CO2, right? Because the venous side you have more CO2. So the higher CO2 will get your pH down a little bit. Okay, so 5 will get it to 7.36. So close enough, so 7.35. Now venous capillary, you have arterial side of the capillary and venous side of the capillary. So when you get capillary blood gas, you get a little bit of mix. Sometimes a little bit here, sometimes a little bit there. So it's somewhere in between. Now is the difference in pH between arterial and venous. This is normal adult values. Okay, not necessarily what we want in a baby. Okay, we will accept different blood gas because we don't want to ventilate and cause lung damage. So 7.4, venous 7.35. So the capillary blood gas will be what? Somewhere in between, right? So the difference is large or small difference? Small difference. So capillary blood gas will accept the pH. How about CO2? Here is 40, 45. As I mentioned, these are normal adult values, not what we accept. We can accept different values in a newborn or a premature baby's on vent. But the capillary will be somewhere in between, right? So, okay, if it comes 44, 45, 46, close enough. So the capillary blood gas is meaningful for pH and PCO2. Now, PO2 is 100 in the arterial side, it's 40 in the venous. So what is it in the capillary? Somewhere between 40 and 100. So maybe 50, 60, 70, 80. So we don't go by arterial. When we look at capillary blood gas, we don't look for PO2. Oxygen status, I'll get it from the saturation monitor. So those who do capillary blood gas look for pH and PCO2. You're only doing acid-base balance. Oxygen is a different story. You want to do oxygen, you need an arterial blood gas. Okay? Now, oxygen saturation, 95, venous 70, and we'll talk about that in a little bit. Okay? So clear the difference, and when you do capillary, venous, actually PO2 in the venous is more, reflects the oxygen extraction rather than the oxygen on the arterial side. It's both oxygen on the arterial side and oxygen extraction. So if you have very low PO2 and a normal arterial, very low O2 in the venous and a normal arterial, you have high metabolic rate and you have high extraction. If you have high venous, then you're not extracting well, which is not good either. So it reflects something completely different from blood gases. So capillary blood gas, venous blood gas, look pH, PCO2, and do acid-base balance only. Do not do oxygen. Okay. So this is a chart, but you don't need to remember it if you know the principles. Okay. Now, when you want to say this baby, I come and look at, say this baby looks blue, and you say, no, he looks pink. How do we decide whether the baby's oxygen is good or not? What are the things you look at? The measurement. How do you measure oxygenation? If I want to know how well you're oxygenating, sitting here, listening for lectures for 3 hours so far. So how can I tell how much, how can I express your oxygenation?
My color.
Color, okay, color, I'm color blind. Anything else? Pulse oximeter. Pulse oximeter will give me what? Oxygen saturation. So pulse oximeter will give me arterial oxygen saturation. Okay, what else? How else can I express oxygen? Partial pressure of oxygen. So I do arterial blood gas and I get partial pressure, which reflects oxygen dissolved in the plasma. Oxygen saturation will reflect how much in my arterial blood is oxyhemoglobin versus deoxyhemoglobin. Okay, how else can I, there is one more way to express oxygenation. Okay, if your hemoglobin is 15 for a normal adult male, and your hemoglobin is 10, and you both have the same exact saturation and partial pressure of oxygen, do you have the same amount of oxygen in your body? Yes, no, maybe? Why not? Okay, so how can I express the difference? They have the same PO2, same saturation, different amount of hemoglobin. How can I express that? There's something called oxygen content. Okay, so oxygen content is the amount of oxygen that is carried in 100 ml of blood. And that depends on saturation and hemoglobin mainly. Each gram of hemoglobin will carry 1.36 ml of oxygen at 100% saturation. So if you're well saturated, the more hemoglobin you have, the more oxygen you will carry. And that's why if you have a sick premature baby, you want them to have good hemoglobin so you can have good delivery to the tissue of the amount of oxygen. Okay? So 3 ways to calculate. We'll just do one. Hemoglobin dissociation curve. Everybody has to know this one. Okay. This is PaO2 and this is oxygen saturation. Two things to note. First, this is PO2, 10, 20, 30, 40, 140. If I give a normal adult 100% oxygen, the PO2 can go up to 650. Okay? How about saturation? How high can it go? 110%? No, 100% and we'll stop. So as you can see from here, 98, 97, 98 saturation is a flat line. So if you have a baby, you're giving him oxygen in your unit and his saturation is 99, 100. What is his PaO2? Somewhere between 90 to 650. Is this what you want? Is this good for the baby? No. High PaO2 will cause eye problems, it will cause blindness, cause lung damage. Okay? So I don't want to see, if I'm giving someone oxygen, I don't want to see saturation of 100 or 99 because I have no idea what his PaO2 is. Okay? So if he's 100% saturation in room air, that's perfectly fine. It's somewhere within this curve. Okay. So very important. If you give someone oxygen, you have to put a limit, alarm limit. So it will alarm when it hits 98, so you can decrease the FiO2 you're giving. Okay. The second part of this is the adult oxygen hemoglobin curve, because you can see the steep part of the curve. I guess we'll see it better this way. Okay. Same curve, S-shaped curve. Now we have right shift to the right and shift to the left. I usually forget what makes things shift to the right and shift to the left. Do you always remember? So I mark them in a way that can make me remember. Now, which one has more oxygen to the tissue? If your hemoglobin is holding on to the oxygen, if the saturation is high, then it's not delivering it to the tissue. So if you look at this number, which is around 27, this here, saturation of 40, while this here, saturation is 60. So the one to the right gives more oxygen to the tissue, or the one to the left? The one to the right is giving more oxygen to the tissue. When do you want to have more oxygen to your tissue? When you're healthy or when you're sick? When you're sick. So what things makes you sick? Or what happens to you if you're sick? What happens to your temperature? Goes up. What happens to your pH? Goes down. What happens to your PCO2? Goes up. Right? So if you're sick, you shift the curve to the right. So temperature, high CO2, low pH will shift it to the right. Okay? 2,3-DPG you have to remember. Okay? There is more 2,3-DPG that will shift you the curve. If it binds to the hemoglobin, it will shift the curve to the right. Okay? So fetal hemoglobin, they're living in a low oxygen environment, so they want to hold on to the oxygen more to be able to deliver it to the tissue. So actually the difference, fetal hemoglobin does not bind to 3-DPG good, as well as adult hemoglobin. So that's why the curve is shifted to the left. Okay? So these are the two things you need to remember in the oxygen dissociation curve. Now, if you go downstairs to the baby's premature baby and you do arterial blood gas, you get saturation in the arterial blood gas. Which saturation will be higher? The one in the arterial blood gas or the one in the pulse oximeter? Those who are doing arterial blood gas, what do you notice? Which one has higher saturation? The saturation monitor or the one in the arterial blood gas? This should be the same. For you, it should be the same. For the baby, the saturation on the monitor will be higher because the baby has fetal hemoglobin, unless you transfuse him a lot. Okay, while the blood gas machine will plot it, it does not measure saturation unless you have something called co-oximeter. It actually measures oxyhemoglobin. But the regular blood gas machine puts it in the curve for adult hemoglobin. So you'll get a reading that's a little lower because it's shifted to the right. The adult hemoglobin curve is shifted to the right, so it has lower saturation at the same PaO2. Okay, let us do this. This is called alveolar gas equation. Now we really need your calculator. Okay. How much oxygen is in the room air now? What is the partial pressure? مستشفى أحمد ماهر is sea level. So we'll assume it's a sea level. Okay. So what is the barometric pressure at sea level? You have to remember these numbers. 760 millimeter mercury. Okay? So sea level is 760 millimeter mercury. If you go up, what happens? The pressure goes up or goes down? Goes down or goes up? Okay, it goes down. Okay, because the column of air on top of you will become shorter. So sea level is 760 millimeter mercury. Okay? Now, how much oxygen are you breathing now? 21%, right? So 21% of the 760 is the partial pressure of oxygen we're breathing. Partial pressure is pressure, 760 millimeter mercury. 21% is percentage of oxygen from the air we're breathing. So 21 out of 760 is how much? 0.21 times 760. Where is your calculator?
150.
Okay, about 150. So the partial pressure of oxygen in this room is 150 millimeter mercury. Okay, by the time it gets to your alveoli, what happens to it? Two things. First, it gets humidified, right? That's why if you talk a lot like me, then you'll get dry throat, because it takes the humidity from your upper airway before it goes to the lung. So it becomes 100% humidified. Second, the alveoli has how much CO2? How much CO2 is here? A lot, little, not much. No smoking. So it's 0.003%, nothing. So zero. Okay, and the alveoli, as we've mentioned, it equilibrates with the blood. So it's 40 millimeter mercury, partial pressure. So there's alveoli, there's CO2, and there's water vapor, humidity. So this is what we get from this. If we want to know what's in the alveoli, it's the partial pressure of inspired oxygen, which is FiO2 that we're breathing, times the barometric pressure minus 47, which is the pressure of water vapor. Okay, it's becoming a little complicated. Okay, we'll do it. Okay, so we mentioned it's 150 here. By the time it gets to our alveoli, it gets humidified. So we have to subtract we already mentioned Fi 2.21, and we multiplied by the barometric pressure. We can either subtract the 47, multiply it first, and subtract by 47. It comes about both close enough. Okay, so FiO2 times barometric pressure minus 47, which is the partial pressure of water vapor. So 7.21 times 760, which is barometric pressure, minus 47. How much is that? Okay. Okay. Okay, we'll try to simplify it a little bit. Because it's important when you have babies on oxygen. You need to know the alveolar oxygen, because if you do alveolar arterial gradient, it will tell you how sick the baby is. So this is important, because if you have like more than 600, that's mortality 80%, ECMO indication. So it's important to know the equation. Okay, you don't need to remember it completely, but just know. Let us see. And there's a big difference between what's in your alveoli and what's in your arteries. Is this good or bad? You want to have a big difference or a small difference? Small difference. Normally it's 10. Okay? because the more difference means you have to get more oxygen to deliver more oxygen to your organs, to have more oxygen in your body. So normally the difference should be small, 5 to 10. If you have a big difference, then that's a problem. It means the person is sick. If the difference becomes bigger, it means the person is becoming sicker. If the difference is becoming smaller, it means that the baby is getting better. So it's good idea. You can obviously, you understand that by yourself. If you were looking for saturation of 95, for example, and you need to give the baby 80% oxygen, then at night you only need to give him 50%. So you would say, if he's getting better, he was requiring 80%, now he's requiring 50% for the same saturation, then I'm doing okay. The opposite is true. If he's requiring 50% in the morning and at night it's 80%, it means something is going wrong with the kid, right? So the amount of oxygen you need to deliver in the alveoli to achieve certain saturation or partial pressure of oxygen in the blood is important, and you should register that. If he's getting better, if he's requiring less oxygen, then he's doing better. If he's requiring more oxygen to achieve same saturation, then he's doing worse, because now he needs more oxygen in his alveoli to be able to deliver it, because the gradient is becoming bigger. So the difference between the oxygen in the alveoli and the oxygen in the blood is important, and you can only tell that in an arterial blood gas or by having the same saturation and different oxygen concentration. Okay, I guess we'll skip this part. We may talk a little bit about it in the workshop to just get it, because in a big group it doesn't work very well. You really need a pen and paper and a calculator. As I mentioned, this is the tough part about how to calculate this. But actually people who take exams in respiratory medicine or neonatology, they will tell you this is arterial blood gas for a baby in a sea level place, and I want to send him to the mountain at elevation of this much. How much the FiO2 that you should adjust to when you get there. Okay. Last thing, if you go in a plane, what happens to you? What happens to the oxygen in the plane? Goes up, goes down, stays the same. Goes up, raise your hands. Goes down, raise your hands. Stay the same, raise your hands. Okay. So the planes are pressurized to 10,000 feet. So when you're on the plane and it's 35,000 feet, it's as if you're 10,000 feet above sea level. So the partial pressure of gases are less. Remember we said 760 at sea level, you go up, it becomes less. So the part of the oxygen is still 21%, but now it's 21% of 580, not 21% of 760. So it's as if you're breathing 18% oxygen. Okay, so people who are sick, who have respiratory problem, or borderline, or you're sending a baby to somewhere on a plane, make sure that you compensate for that. Okay, because your oxygen will go down a little bit. That's why people who go on long trips, they get a little swollen hands and feet because they have a little hypoxemia. Okay, I guess we'll stop here. Any questions? I know it's a little math, it's not easy stuff, it's a little dry, but important things. Any questions? Okay. At least I'm good in math, so that's not bad. Yeah. Okay, now we can get a break? Okay.
Thank you, Dr. Alaa. We'll take a break, please, 10 minutes only. 10 minutes only.
انت عندك الورك شوب ولا
العلم يحلو كلما كررته ولذاك عدت مكررا لحلاوته وبكثرة التكرار يكثر نفعه وبكثرة التكرار يكثر نفعه فادأب لتعلم من فوائد حكمته